Okay, thanks everyone for being back in time, and we're going to start with our last session of the day, and this is going to be another fascinating debate that will hopefully answer all our questions on this really important topic of should we be treating high-risk smouldering myeloma. And we've got another two debaters, but before we get to them and I'll introduce them, we'll just look at the case to illustrate our point. So this is a 55-year-old woman. She was originally admitted to hospital with acute hematuria, UTI symptoms, but during the course of investigations, her bloods revealed that she was marginally hypercalcemic, but did have a very high total protein unexpectedly. And that led to some reflex testing, which demonstrated that she had slightly suppressed IgA and IgM levels, but very high IgG level, and electrophoresis showed a 24.5 gram per litre paraprotein, which was shown to be an IgG kappa paraprotein. So she was referred to haematology, and when she came to it was completely asymptomatic and had had her UTI treated and felt completely well. She had some completion bloods done at a point where we were just using ISS for staging, and those were the results, so low B2 microglobulin or normal level, and normal level of albumin. And she'd had a bit of further investigation of the marginal hypercalcemia, which had revealed that she did actually have hyperparathyroidism, primary hyperparathyroidism, and you can see there very low vitamin D level. So she had a serum free light chain assay done to complete looking at myeloma markers, and you can see the slightly raised kappa light chain with a ratio of 6.6 overall. She had a whole body MRI, which demonstrated no evidence of focal lesions, and a bone marrow biopsy that showed 27% infiltration with plasma cells with a malignant phenotype by flow, and a similar sort of infiltration on the trophine. And in the genetics, found to have a deletion of TP53 in 70 of the 100 nuclei, but no other high-risk markers identified. So she had a DEXA scan done, which showed she was osteopenic at the hip and the spine, and then she went on to be referred to the endocrine team for that and the hyperparathyroidism. But in summary then, a 55-year-old who presents with no Crabbe-Slim criteria, 27% plasma cell burden in the marrow. You can see there the level of the IgG paraprotein, slightly abnormal serum-free light chain ratio, and the evidence of deletion of TP53. So with that in mind then, please can you vote on the best management plan? We've narrowed down options for you for this case. So your options are you can closely observe the patient for a bit longer, you can give them close observation plus some myeloma intensity bisphosphonate, or you could treat at this stage with a high-risk smouldering myeloma regimen. Now, we're not asking what you're able to do in your practice, but what you think the best management plan is, and that's, of course, the purpose of this debate. So if you could state that rather than what you would be limited to by your MDT. I think we're nearly there. Yeah, okay. Okay, interesting. So when asked what you think the best thing to do is rather than what we can do, just under half people would say they closely observe. We've got just under a third who closely observe plus give bisphosphonate in whatever your myeloma intensity regimen is for that. And then just over 20% who would want to treat this patient as they've got high-risk smouldering disease. So that's an interesting start, I think, to our debate. I'm going to introduce the two speakers and then let them have the floor. So arguing for treating high-risk smouldering myeloma, we have Dr. Dean Smith, who's worked as a consultant haematologist at City Hospitals Nottingham since 2015, specialising in myeloma, and more recently he was appointed Associate Professor at Nottingham University. He's an active member of the UKMRA and a particular interest in precursor diseases, and is chief investigator of the investigator-initiated MODIFY trial. He's also a member of the BSH Myeloma Guidelines Group and co-author of the BSH Guidelines for the Investigation and Management of Newly Diagnosed Myeloma. And in the other corner, we've got Dr. Jamal Kathari, who's a consultant haematologist at Oxford University Hospitals, clinical lead for myeloma for Oxford and the Thames Valley. He trained at UCLH before joining the consultants at Oxford in 2014, and as well as myeloma, he has an interest in Waldenstrom's and has led numerous clinical trials in both myeloma and Waldenstrom's. So as you can see, we've got two heavyweights, and we now await your opinion about whether or not they're correct for their argument. Thanks.
Thank you, and thank you for inviting me to hopefully convince everyone that, yes, we're now at a stage where we should be treating high-risk smouldering myeloma. And to do that, I'm going to talk through the following topics. Going to talk about why we actually have the need to treat high-risk smouldering myeloma, what the biological rationale is for the treatment, then what some of the evidence is that we have thus far for treating high-risk smouldering myeloma. We'll consider what expert guidance and guidelines tell us so far, and I think most importantly, what the patient perspective is. So why should we be treating high-risk smouldering myeloma? Well, essentially, if we don't, high-risk smouldering myeloma patients are at high risk of early progression to active myeloma with the resultant risk of end organ damage. There are a number of risk stratification models which can be used now to predict the likelihood of a smouldering myeloma patient transforming to active myeloma. So it's no longer just the days where we'd say it's 10% transformation per year. One of those models is the Mayo 2220 model, which looks at tumour bulk. So that's paraprotein level, light chain ratio, and bone marrow percentage, scoring a point for any of those being over 20. The IMWG model takes that and adds in high-risk cytogenetics as well. So if we look towards the table at the bottom, those patients that are intermediate risk score 2 out of 4. Those that are high risk are scoring 3 or 4 out of 4. And respectively, they have a 46% and 63% chance of progressing to active myeloma and probable end organ damage at 2 years. So I would propose that rather than wait for that to happen, we should be intervening early to try and prevent it from happening. Now, I appreciate a counter-argument could be that we can just monitor these patients closely and try and act before end organ damage occurs. But actually, there's some evidence that observation alone may be insufficient to prevent end organ damage. This is some real-world data from the Mayo Clinic, where they serially followed a number of high-risk patients via the 2220 model. And the median time between appointments was 3 monthly, which I think is probably quite standard for what we all do. The median time to progression to active myeloma was around 2.5 years. And despite this quite close monitoring, almost half the patients presented with a clinically significant myeloma-defining event. And by that, I mean either hypercalcemia, renal insufficiency, or bone lesions. There's also some evidence that high-risk smouldering myeloma is associated with reduced overall survival. This is some data from the Czech Registry of Monoclonal Gammopathies, which is actually one of the biggest European databases for monoclonal gammopathies. And they've got serial long-term follow-up of their smouldering myeloma patients. And they divided them into 2 cohorts, either high-risk or non-high-risk, again using the Mayo 2220 model. As you can see there, the overall survival was significantly inferior for those that were high risk. So again, I'd put it to you that now is the time we should be planning to act early to try and improve this poor prognostic outcome for the high-risk group. Now, there are those who don't want to treat high-risk smouldering myeloma, and one of the arguments may be that we shouldn't treat because there's no conclusive evidence of benefit. I'd counter that with a couple of arguments. Firstly, no evidence of benefit doesn't necessarily mean that there's evidence that there's no benefit. It might just mean that the right trial's not yet been conducted or reported. But also, what does evidence of benefit look like? Prolonged PFS, reduced organ damage, improved overall survival, because there are trials in smouldering myeloma that have read out so far that have showed benefits for those metrics. And I think prolonged PFS is sometimes considered maybe not the most important readout in smouldering myeloma. But as Jan pointed out in the last question session, it's quite a conveyor belt now of myeloma treatment for active myeloma. And when patients start on that, it's quite hard to have a treatment-free interval. So if we can significantly delay the time until then by giving fixed duration therapy for high-risk smouldering myeloma, then I think that would be beneficial to patients also. Another counter-argument I hear is that we shouldn't treat smouldering myeloma because we don't have a standard of care currently. Well, I think that's on us. We need to establish the standard of care. We need well-designed clinical trials. We need to consider the biological rationale when designing the trials. We need to select appropriate endpoints, and we need to consider both efficacy and, I think very importantly in this patient cohort, we need to consider tolerance of treatment as well. If we move on to the biological rationale and just the biology of smouldering myeloma in general, just stop for a moment and we'll think about what are the pathways that lead to transformation to active myeloma from smouldering myeloma. And it can be at least threefold. You can get increase in tumour bulk, you can get increased complexity of genomic aberrations, and you can get reduced immune fitness, which can lead to a reduction in how well the immune microenvironment controls the malignant clone. So if we take that forward and think about the biological rationale for treating smouldering myeloma, treating early should mean that there are less genomic complexity, and we're treating before aggressive subclones have grown out. We're treating when there's a fitter immune system, so we would therefore hypothesize that the immunomodulatory therapy should have greater efficacy used earlier when the immune system is fitter. So that means that we're not just moving the treatment threshold forward from CRAB to slim CRAB to smouldering myeloma, but there's a clear biological rationale as to why giving immunomodulatory therapy in the smouldering setting should give us a greater return for that treatment investment. The patients, by definition, should not have end organ damage, so they should have a higher performance status and tolerate therapy better, and hopefully with fewer adverse events. And putting all this together, we may be able to achieve long-term survival, even if we're not eradicating the malignant clone completely. And there's some clinical data to back up that theory. So if we consider the ECOG study, which was lenalidomide monotherapy compared to observation, the lenalidomide monotherapy was given for a median of 23 cycles, then the outcome of this told us that deep remissions may not necessarily be required to improve outcome in smouldering myeloma. If I could ask you to look at the survival curve on the right, what we have there is progression to active myeloma. And you can see that patients that were treated with lenalidomide had significantly prolonged times until they transformed to active myeloma compared to observation alone. And if you then look at the hazard ratio at the bottom of the slide, you can see a hazard ratio of 0.09 in the Mayo high-risk 22-20 group, suggesting that those that derive the greatest benefit from early intervention are the high-risk smouldering myeloma group. But it's also interesting to look at the response rates on the left-hand side. The overall response rate was a fairly modest 54.5%, with not very deep responses. The majority were partial responses. And from this, I think we could infer that preventing CRAB features in smouldering myeloma is driven not only through response, but also through immunomodulation, which is backing up what we saw in the biological slides previously. On top of this, there's evidence that lenalidomide and dexamethasone can improve not only time to progression, but also overall survival compared to observation in high-risk smouldering myeloma. This is some data from the Curadex trial, and I draw your attention to the overall survival curve on the right, where the median overall survival for patients who were observed was 8.5 years. Those that were treated with lenalidomide and dexamethasone, the median overall survival is not reached, and that's a significant difference. So again, a counter-argument I sometimes hear to treating smouldering myeloma is the concern that it will induce clonal progression and lead to emergence of more resistant disease. Well, if we go back to the Curadex trial, then there's evidence that that is not the case. Early treatment with lenalidomide did not induce more resistant relapses. So we can see here that this is a survival curve from the time that each patient progressed to active myeloma. And for both arms, there was no significant difference. In fact, there appears to be a slight trend for patients doing better from that time point onwards if they'd previously been treated with lenalidomide and dexamethasone, median 6.4 years compared to 4.5 years. And it's also worth highlighting that the rescue treatments used were evenly matched in both arms. What does expert guidance tell us to do? Well, we can look at EMN consensus statement, EHA guidelines, BSH good practice papers. There's also NCCN guidelines in the States, and they all suggest that we should be entering patients into clinical trials if they have high-risk smouldering myeloma. And finally, what do patients think about this, which I think is a real key aspect. So I think it's important that we don't underestimate the impact that watch and wait or watch and worry can have on patients. There is evidence that the psychological aspect and the anxiety that patients can feel is equal in smouldering myeloma compared to active myeloma. And I think there will be a cohort of patients who want to take back control and want to have their condition treated early. And we have evidence to back that up from the preference study, which was run in America. In this study, the investigators looked at almost 300 patients with precursor disease, and they asked them how much weighting they would put on 4 specific attributes. And that's preventing myeloma, the cost of treating myeloma, the inconvenience of treatment, and the risk of long-term side effects. And they found that there were 3 different profiles which most patients fitted into one of them. There were patients who predominantly valued the avoidance of side effects. There were patients who were concerned about keeping the cost of treatment low, which fortunately we don't have to worry about in the UK. But there were patients who valued prevention of multiple myeloma above other attributes. And there was a similar split between those that wanted to avoid side effects versus those that wanted to prevent progression of myeloma. So as I said before, I think there will be a cohort of patients that want to be treated early. So putting all these arguments together, I believe that treating myeloma is actually a potential model for how we should be using cancer therapy. If we think of early diagnosis and treatment, maximizing efficacy whilst minimizing toxicity, reducing morbidity, having a patient-centered approach with shared decision-making, all of those aspects can be covered if we intervene and treat high-risk smouldering myeloma. So, in the context of treating in a clinical trial, and after a shared decision-making process with the patient, I believe that yes, we should be treating high-risk smouldering myeloma. Thank you.
Hello, everyone. Last talk of the day. It's hard to go up against Dean, isn't it? The nicest man in myeloma. His beloved Nottingham Forest also got a 4-point penalty this week. Last night, he got to his hotel at 1 a.m. and there were no rooms. He spent all night at King's Cross Station, and I still have to do this to him. But the short answer is no, we should not. So before we get there, just humour me for a minute. I'm going to talk about Marshall Mathers, also known as Slim Shady. So this is the Slim Crab. So before we talk about... I'm glad, actually, someone's actually appreciated that. I thought there'd be complete silence. He actually turned 50 this year, which actually makes me feel very old. But that's not really the point of this talk. But... So before we get to high-risk smouldering myeloma, well, what about Slim Crab? It's been 10 years since the IWMG told us that Slim needed to be treated. But also, how well has Slim actually aged? Terribly. I think, as we all know, and as you all see in your clinics, this was a nice meta-analysis by Ludwig and colleagues from last year. And just very briefly, top-line analysis is that, and we know this, that people who have light chain ratios greater than 100, or even heavy marrow infiltration, they progress a lot more slowly than we thought they were going to, and patients clearly have been overtreated. So what I'm telling you is that you don't even treat all your patients with symptomatic multiple myeloma, so why would you treat high-risk smouldering myeloma? I rest my case. So the first thing I'm going to say is, okay, we're talking about high-risk smouldering multiple myeloma, but what is it? And I would argue that we don't really understand what it is. Now, there are a number of models. Dean showed us the IWMG model. This is on the left panel is actually the Mayo 2020 model, which looks at 3 specific criteria, paraprotein, bone marrow infiltration, and light chain ratio greater than 20, and you get a separation of 3 curves. But as you can see, there's still plenty of patients that are even high risk who have not progressed at 5 years. The Spanish classification is older, using immune paresis and phenotypically abnormal plasma cells. And again, you have 3 groups. But as you can see, that even in patients that are shown to be intermediate or higher risk, there are a significant proportion of patients who haven't progressed at 5 years. And the problem is that there is very poor concordance between these different models. Now, this is from JAMA Oncology in 2021, essentially just looking at 3 risk stratification models, the Spanish PETHEMA model, the Mayo 2008, which is similar to the 2018, but you have to have a lower bone marrow infiltration, and the light chain ratio levels are slightly different as well. But as you can see, there is very little concordance when you look at low, intermediate, and high, and that's on the left-hand panel. And even if you just separate non-high risk and high risk, there's very little concordance on what a high-risk group actually is. More recently, the Dana-Faber have come up with the Pangea models, and there's a nice calculator on the internet where you can put in various bits of data, which is generally easily obtainable, some which have bone marrow in, some which have fish in, and there is lots of information showing us now that actually the rate of what looks like low, intermediate, and high is very different depending on what model you are putting your patients into. So I think a really important point to make is like, should we treat high-risk smoldering multiple myeloma? I would argue that there isn't any clear guidance on that we really understand what high-risk smoldering multiple myeloma is. But if we have a defined group that we're going to treat, then, well, what do we need to see? These patients are asymptomatic by definition. So clearly there are nuances in the way we're thinking about treating these patients, but clearly if you're asymptomatic, and I'm not discounting the psychological morbidity that Dean touched on, but you have to show that people live longer than the standard of care. And I'm going to argue that that standard of care should still be observation, and you should see an overall survival benefit. We're not talking about patients that are symptomatic and need to have treatment where we can think about surrogate markers, whether it be PFS or MRD. I think overall survival has to be the metric that we look at. Is it safe? You're going to have less side effects on no treatment, and some side effects can unfortunately be very, very significant. If you treat the disease earlier, is there any evidence that anyone can show me that you're making it inherently more treatable? I think Dean correctly touched on the fact that if you are treating at earlier stages, maybe it is inherently more treatable. If you could convince me that actually by treating smoldering myeloma, you're going to get everyone to a very deep MRD negative CR, which is sustained, well, that's interesting, isn't it, potentially? Or do you affect the natural history in a positive way? By immune modulation, do you change clonal evolution? Do you change other aspects? Are they less likely to get bone disease? These things would be important, and if there is evidence that that happens, then that is interesting and worth looking at. Are you going to improve quality of life? These patients are asymptomatic, but I would counter that, yes, psychological morbidity is important. In other disease areas, a number of you will remember the rituximab versus observation watch and wait study in follicular lymphoma. That study showed that by giving patients rituximab, you reduced psychological morbidity, and that was very nicely documented in the Lancet paper from around 10 years ago now, and that is some decent evidence in an allied disease area. End organ damage. We spend a lot of time thinking about it. Of course we do, because it's important. But are we confident that prevention of end organ damage is irreversible and morbid? Not all end organ damage is created equal, and some are more reversible than others. So I've got a couple of slides on the 2 studies that Dean presented, the Quiridex study and also the American study from 2020. A couple of points to make. The Quiridex study on the left there, 10 years old now, so no patients in that study had modern imaging techniques. You only had to have skeletal surveys to get in, so we really don't know how many of these patients actually had symptomatic disease that needed standard sorts of treatment. The study also wasn't powered to look at overall survival, and the numbers in each arm were small. So I think certainly 10 years on, I don't think we can really look at that study, and I don't think it helps the argument of treating early. With overall survival as the metric that I argue that we need, the bottom panel there on the right is the overall survival curve in the Len versus observation study from the States. As you can see, it's completely overlapping. I think that is important. I think what is also extremely important, this is the patient disposition in this study. And just look at how many low-risk patients there are in the study and how many intermediate-risk patients there are in the study based on both the Mayo 2008 and 2018 criteria. I've just put the criteria below the patients, but there are a significant majority of patients that would have not progressed 5-6 years, for a minimum of 5 to 6 years. These are not high-risk patients in any way, and as actually they are open in the study, they had to change the inclusion criteria to actually get the study recruited. So this is not a study of high-risk smoldering multiple myeloma. Okay, so if you're going to treat it, then, well, is it safe and what are the risks? So this is the Spanish study, the GEM-CSER study, which was initially presented at ASH, I think a couple of years ago, and this was a curative approach. So this isn't the type of more nuanced approach that Dean was alluding to. This was, we're going to treat it early, we're going to treat it hard. So a standard kind of induction approach with a triplet this time, transplant and then consolidation and maintenance. And this is a lot of treatment, but after quite a lot of treatment, if you look at how well people have done, yes, there is a significant amount of MRD negativity after defined time points. But when you look at this and compare this to other studies where patients have needed to start treatment for symptomatic disease, it doesn't really look that different. So it's very similar to Forte, for example, which is a similar sort of approach, KCD or KRD, followed by a similar sort of transplant, consolidation, and maintenance strategy. So I don't think you can argue that treating it earlier makes it inherently more treatable on the data that is out there. And of course, well, people died on this study, and I'm not going to start sort of saying carfilzomib is a terrible or toxic drug, but we all know the toxicities of combinations of drugs that we all use. And I think my point about this slide mainly is that, well, there's no control group. Patients die in control groups, patients get heart attacks and all sorts of problems in control groups. And there are lots of big studies, again, in similar disease areas. The Germans did ibrutinib versus placebo for asymptomatic CLL. And you could actually have a meaningful discussion about toxicity because patients died in the observation arm as well, and there were AEs in the observation arm. Clearly, you look at some of these toxicities, and you think they're probably partly related to some of the drugs that were given, clearly. And this is from a starting point of a patient basically having no symptoms at all. Okay, so what about end organ damage? So not all end organ damage is created equal, and I think this is a really nice study. This is being run in the States by a few centers, and essentially what they're trying to understand is who gets morbid end organ damage, and they're looking at that by basically doing an observational study with lots of imaging, bone marrows, and understanding is like who are those patients that really get end organ damage that is not reversible. So I think this is an area that has been poorly investigated so far, and I think this will certainly add to the discussion. So, in summary, you don't even treat all patients based on SLIM before we even get to high-risk smoldering multiple myeloma. We can't agree on what the disease actually is, and I think a lot of progress is being made with all the biological and profiling studies that are being done in this space. There is no appropriately sized study showing an overall survival benefit against observation that has a better population that we would think is definitely not low risk. Recent trials haven't shown that smoldering myeloma is more inherently treatable, and people have died on these studies. Could end organ damage be avoided? Not always, for sure, but I think there is research being done to try and understand if we can better characterize how this can be done. And I think this is a reasonable point that, pushing the can down the road is helpful. Now during induction, we're giving patients, of course, quadruplets and maintenance with transplant. And we know that when standard risk patients progress in 4 or 5 years, the landscape's going to look very different to them. It's a similar potential argument with smoldering myeloma as well. This doesn't come out very well, but this is from Blood. There's a very nice article just from a couple of weeks ago, just an observation about a number of these points. So I would encourage you to have a read. And that's it. Thank you.
At the front, while we've got our last few minutes for questions, and while they're doing that, it would be great to have the voting slide up again and see what you all feel now about the case that we looked at the beginning. So that should be up in a moment. So if you remember our case, this is a patient that I think had two high-risk features in terms of plasma cell load in the marrow, size of paraprotein, depending on which risk stratification you're using, and also is TP53 deleted, if you remember. So we've got close observation, bisphosphonate, or treating. So we've got votes rapidly coming in here. I can sense the tension on this side of the table.
Do I need to sit in between them?
Okay, so I think we're probably pretty much there. Let's see if we can have some results. Okay, I think the needle has moved in favour of not treating, it looks like, from those percentages. So I don't know whether we declare Jam the winner there, or we can just presume anything else. But okay, thank you everyone for replying to that, and it would be great now and for such great talks as well in what is a really, really important debate and clinically very relevant for us. So any questions, either online, please put them in on the Q&A, or in the room.
Thank you. They're very nice talks. I have a general comment to make, but before that, I would like to ask Jamal, what design of trial and what level of evidence would convince you to treat high-risk smoldering myeloma?
It's a good question, Queen. I think the point you're alluding to is that without a surrogate, if you have a randomized trial with overall survival as the endpoint you're looking at, you're never going to get.
No, you're not allowed surrogate. You said you wanted overall survival.
No, I do. I want an overall survival. I want a randomized trial with observation. I suppose the question is what's the intervention arm? Is the intervention arm, if you're going for a curative approach, then you're looking at a quadruplet with a full myeloma trope. So that's a curative approach. But if you're going for the kind of study that yourself and Dean and Karthik are looking at, then that's a sort of an immune modulation approach. I think either approach, I think is fine if you have if you counsel the patients and you have observation as the control arm, and you have overall survival as the endpoint that is the metric that you need.
And what margin of benefit would you look for? Convince you?
I think you'd probably need quite a big sample. I think you'd need a big sample size. I think that's the problem. I think I'd need to see, with whatever sort of statistical analysis plan the study has, I'd need to see that it met its primary endpoint and it was an appropriately powered study where either arm showed a statistically significant overall survival benefit.
Yeah, so it is difficult designing trials. That's what the problem is. But I have a quick comment, and I'll pass the mic on to Curly. I do think we should treat high-risk smoldering myeloma. I think just because we can't identify the right patient group and we don't know what the right treatment is no reason is not a good enough reason to say we shouldn't. I think what it tells us that we need to adopt the challenge of figuring this out, Or we could sit back and let the rest of the world figure it out. And then when a licensed treatment comes about in 5, 10 years' time, we can say, aha, that's what we will do. Everybody else has done the hard work for us. Or we can engage with the questions and the issues and try and figure this out. But you're right, Jam, it's difficult. I do think there's a group of smoldering patients who really have myeloma. They just haven't declared themselves yet, and we should treat them as myeloma. I think there are problems with the slim crab criteria, and I absolutely agree that the light chain criteria is the softest and the weakest of all, and we often don't treat those patients. So the high-risk people, they should be treated as myeloma. But if what we're after is early detection and prevention, then we need to design and devise a good strategy, not to treat it as cancer, but to prevent progression to myeloma. And that's where the big challenge is, really, in the intermediate risk group of patients. And I think immunomodulation, the way it's being developed for cancer, it holds a lot of promise and potential. But there's a lot of work to do. I'll have to stop here.
Quay's made a very important point. I'm going to ask a much more simple question. That is, about a third of the audience was very keen on giving the patients bisphosphonates intensively, but neither of you actually touched on that, and it's something I quite like the idea of, because there is some evidence that bisphosphonates may be helpful. Would you like to comment?
I mean, I think that's a low-risk intervention that is absolutely worthwhile, because you're not going to... I haven't killed anyone on a bisphosphonate yet. So, you can give something like that and realistically get, there's some trials, right, of bisphosphonates in smoldering myeloma that have shown, I think, some PFS benefit, I think, from memory. But I certainly would think it's reasonable to give this patient bisphosphonates.
I think in the context of them having osteopenia, I would give bisphosphonate. I guess the only question is dosing frequency and whether you give a myeloma regimen or whether you give an osteoporosis regimen. I think the recent BSH good practice paper said there wasn't evidence to give enough evidence to warrant giving a myeloma sort of dosing regimen, whereas IMWG paper does suggest that you can consider that sort of approach in high-risk smoldering myeloma. I think I'd probably give more of an osteoporosis regimen myself, but I don't think the evidence is convincing sort of either way. I think some bisphosphonate would be reasonable there. Yeah.
Can I ask a question, Dean, just from your perspective in terms of treating high-risk smoldering myeloma? So if we're going down that line, what do you feel about the more immune modulation approach versus the curative approach? Arguably, you could answer the question by doing a study that has got 3 arms, a curative arm, immune modulation, and an observational arm. It'll take 10 years to complete, but conceptually, what do you think?
Yeah, I think, there are 2 different approaches, and I don't think we know necessarily which is the best approach at the moment. I think sort of starting from scratch, understanding the biology of the disease more and what impact we can have with immunomodulation will be important. I think evolving risk stratification models will be important as well. I certainly favour an immunomodulatory approach at the moment. Both the underlying biology and the fact that with our risk stratification models, I feel that it's therapy that's going to be quite well tolerated generally in a cohort that is still not treated. I think to go ahead with such an intensive regimen right now, using our risk stratification models, would be maybe a little bit more intensive than I'd want to do right at this moment, but I can certainly see the rationale for comparing the strategies going forwards, yeah.
CAR-T, bispecific antibodies, what do you think about those in smoldering myeloma?
So, there are studies looking at that at the moment. I think they're interesting concepts. I think it's easy to say absolutely CAR-T, bispecifics, infection risk, what are we doing here? And there's obviously something presented at ASH, and automatically people are going to think about the infection risk and the morbidity and mortality, potentially. And I'm not saying necessarily I'd open such a study here tomorrow, but I think there's always 2 sides to everything, and I think the concept of using a bispecific antibody when the immune system is less suppressed by the myeloma. Could mean that you can actually give relatively short doses and relatively infrequent doses potentially with quite long-term impacts. I mean, it may be that the infection risk is much reduced. We know that myeloma burden is a signal for how bad the infections are going to be with some of the bispecifics. So I think there are theoretically, it's not an unattractive idea, but I think we probably need a little bit more information before I'd go down that route.
Any more questions from the room? Okay. Thanks very much to our speakers. That's really good to show appreciation. So coming a little bit over time, apologies for that, but just to say thank you very much to everyone for being here. Thank you very much to all our delegates online. Really useful, I think, to see that in each of the debates that we've had today in particular, such an important part of it has been about patient input and priorities that the patients have got, as well as our demonstrations of our Kaplan-Meier curves. So it's hopefully demonstrate how much shared decision-making matters in these cases, which are really everyday cases for most of us, aren't they, with real issues in them. So thank you, everyone, for demonstrating the importance of that. Thanks to all the speakers, the chairs, and to Dr. Sally Moore for helping draw the programme together. I want to say thank you again to for the generous support of the sponsors, without whom we wouldn't be able to be here and enjoying this meeting. Please do feedback. Your feedback is used every year, twice a year, obviously, with the meetings to inform the next agenda, so we really value that. And just a reminder as well that the talks have been recorded and they will be available on the website for anyone who wants to catch up or if you missed any. One more reminder about the November event. Please get your registration in for that once the email comes round on the agenda for that. And finally, just a big thank you to Wendy from UKMS and to Derry and Alex from Collaborative Conferences. So with that, say goodbye. Thank you very much for being here, and we'll hopefully see you in November.